In this video, we will be discussing about acute and chronic arterial ischemic disorders or acute arterial occlusion or acute limb ischemia. Limb ischemia is a severe blockage in the arteries of the lower extremities which significantly reduces blood flow. Ischemia means a part of the body isn't receiving enough oxygen-rich blood. When this happens, the tissues quickly become damaged and it causes intense pain, numbness, and a slow healing sores on the feet, legs, or hands. It is a serious condition that increases the risk of heart complications, limb amputation, and death. Critical limb ischemia is a chronic condition that is an advanced form of peripheral artery disease, a condition that affects blood vessels in the extremities. Critical limb ischemia implies chronically and should be distinguished from acute limb ischemia. Critical limb ischemia is a severely blocked blood flow to the one or multiple of the legs, hands, or feet. Acute limb ischemia or acute arterial occlusion is a sudden and rapid decrease in or loss of lower limb blood flow, or it is a sudden blockage or closing of one of the peripheral arteries that interrupts blood flow. Acute limb ischemia is most often due to either acute thrombotic occlusion of a previously partially occluded thrombosed arterial segment or to embolus from a distant site. Arterial insufficiency of the extremities occurs most often in men and is a common cause of disability. The legs are most frequently affected. However, the upper extremities may be involved. The age of onset and severity are influenced by the type and number of atherosclerotic risk factors. Acute arterial occlusion may affect any of the limbs, legs, or arms, but it usually affects the legs, and it is often a severe complication of a peripheral artery disease. Critical limb ischemia is a severe stage of peripheral artery disease. Peripheral artery disease occurs when a fatty substance called plaque builds up inside the arteries and restricts blood flow. It is harder for the muscles and tissues to remain healthy and strong or to heal with limited blood flow. Another name for critical limb ischemia is chronic limb-threatening ischemia. Acute arterial occlusion refers to symptoms that start and quickly get worse within a 2-week time frame. A person may have pain in the limb that doesn't go away even after taking rest, should seek immediate help and treatment right away. Chronic arterial disease, also called peripheral artery disease, has symptoms that develop more gradually. Intermittent claudication is a typical symptom a person may experience for a while. This cramping or aching feeling in the legs begins when a person exercises and stops after taking rest for a few minutes. This may lead to acute arterial occlusion. Peripheral artery disease causes chronic limb-threatening ischemia. Chronic limb-threatening ischemia develops when a person has narrowed or blocked arteries for months or years. The most common cause of acute arterial occlusion is a blood clot in one of the arteries. A blood clot can form anywhere in the body, but it's most common in the legs. It is especially common in the superficial femoral artery, which supplies blood to the lower leg. Blood clots are more likely to form in the area where a person has a stent or a stent graft. It is a device that helps the blood flow better, but sometimes triggers clots. And the area where aneurysm happens. It is a weakened, bulging section of the artery. Blood clots occurs where a plaque is. It is a fatty substance that builds up in the arteries when a person has atherosclerosis. Blood clots occurs where a person has a traumatic injury. It can be direct damage to the artery, such as a stab wound. A blood clot may also form in one part of the body and then travel through the bloodstream. This is called an embolus. An embolus can get stuck in one of the arteries and block blood flow. It is most likely to get stuck in the artery with loads of plaque buildup or at the intersection of two arteries. The embolus may originate in many different locations. Sometimes it begins in the heart, including the left ventricle, which is the lower left chamber of the heart that pumps blood out to the body through the aorta. Blood clots may form in the left ventricle as a complication of a heart attack up to 3 months afterward. People with atrial fibrillation have a higher risk of blood clots forming in the left or right atrium. Blood clots sometimes form a replacement valve in the heart that is called prosthetic heart valves. An embolus may also begin in another artery. This is an arterial to arterial embolization. It means the blood clot formed in one artery and then traveled to another artery. Anyone with peripheral artery disease can develop critical limb ischemia. The risk increases as a person gets older. Some medical conditions raise the risk of developing acute arterial disease include atrial fibrillation, diabetes, obesity, peripheral artery disease, recent heart attack, systolic heart failure, chronic kidney failure, high blood pressure, high cholesterol. Other risk factors include family history of vascular disease, IV drug use, lack of exercise, smoking and tobacco use. Now we will see the pathophysiology. Acute arterial ischemia is a sudden interruption in the arterial blood supply to a tissue, an organ, or an extremity that, if left untreated, can result in tissue death. It is mainly caused by embolism, thrombosis of an atherosclerotic artery, or trauma. Embolization of a thrombus from the heart is the most frequent cause of acute arterial occlusion. Heart conditions in which thrombi can develop include infective endocarditis, mitral valve disease, atrial fibrillation, cardiomyopathies, and prosthetic heart valves. Non-cardiac sources of emboli include aneurysms, ulcerated atherosclerotic plaque, recent endovascular procedures, and venous thrombi. Thrombi that originate in the left side of the heart may dislodge and travel anywhere in the systemic circulation. Most emboli block an artery of the leg where vessels branch, for example, iliofemoral, popliteal, tibial, or where narrow vessels are seen. Sudden local thrombosis may occur at the site of an atherosclerotic plaque. Hypovolemia due to shock, hyperviscosity due to polycythemia, and hypercoagulability because of chemotherapy predispose a person to thrombotic arterial occlusion. Traumatic injury to an extremity may cause partial or total arterial blockage. Acute arterial occlusion may develop from arterial dissection in the carotid artery or aorta, or a procedure-related arterial injury, for example, after angiography. Sudden blockage or occlusion from a blood clot immediately cuts off or severely reduces the blood flow to the tissue downstream of occlusion, means below the occlusion. Without adequate blood flow, the affected tissues are deprived of oxygen and nutrients. Lack of oxygen for long term causes ischemia, and that leads to cellular damage and eventual cell death, that is necrosis, if not corrected or treated. The body's inflammatory response to tissue damage can further exacerbate the problem, potentially leading to compartment syndrome or other complications. In some cases, restoring blood flow after a prolonged period of ischemia can paradoxically worsen tissue damage due to free radical formation and other factors. Now we will see the clinical manifestations. Symptoms of acute arterial occlusion appear in the affected limb, usually the leg. The symptoms refer as the 6 P's. First P is pain. Severe pain is the most common and usually the first symptom. The hallmark symptom is intermittent claudication, described as aching, cramping, or inducing fatigue or weakness that occurs with some degree of exercise or activity, which is relieved with rest. The pain commonly occurs in muscle groups distal to the area of stenosis or occlusion. As the disease progresses, the patient may have a decreased ability to walk the same distance as before or may notice increased pain with ambulation or movement. When the arterial insufficiency becomes severe, the patient has rest pain. This pain is associated with critical ischemia of the distal extremity and is described as persistent, aching or boring pain. It may be so excruciating that it is unrelieved by opioids and can be disabling. Ischemic rest pain is usually worse at night and often wakes the patient. Elevating the extremity or placing it in a horizontal position increases the pain, whereas placing the extremity in a dependent position reduces the pain. Some patients sleep with the affected leg hanging over the side of the bed. Some patients sleep in a reclining chair in an attempt to prevent or relieve the pain. The most common symptom of chronic limb-threatening ischemia is an intense foot or leg pain. Next P is pallor. The affected limb may appear pale or bluish in color. Next P is pulse deficit or absent pulses. The pulse distal to the occlusion will be absent or diminished. The next P is poikilothermia, sometimes called polar sensation. It is an adaptation of the limb to the environmental temperature. The skin feels cool to the touch. Next P is paresthesia. A person have a pins and needles feeling. Reduced nerve function can cause paresthesia. Next P is paralysis. Muscle weakness or paralysis can occur due to nerve and muscle damage. If a person detects these signs, immediately notify the healthcare provider. Without immediate intervention, ischemia may progress to tissue necrosis and gangrene within a few hours. Paralysis is a late sign of acute arterial ischemia and signals the death of nerves supply in the extremity. Foot drop occurs from nerve damage. Because nerve tissue is very sensitive to hypoxia, lymph paralysis or ischemic neuropathy may persist even after revascularization. An embolism causes sudden and severe symptoms. In other cases, symptoms may show up over several hours or days. The longer the limb goes without oxygen, the more the symptom will progress. Pain turns into a pins and needles feeling, which finally turns into paralysis. If blood flow is not restored quickly, the affected limb may require amputation. In severe cases, acute arterial occlusion can lead to systemic complications such as kidney damage or heart failure. Now we will see the assessment and diagnostic findings. Diagnosis often begins in an emergency room and includes physical examination. Carefully check the limbs, feel the skin and check the pulse at many different points. Look for visible signs of peripheral artery disease like ulcers on the skin. A sensation of coldness or numbness in the extremities may accompany intermittent claudication as a result of reduced artery flow. The extremity is cool and pale when elevated or ready and cyanotic when placed in a dependent position. Skin and nail changes, ulcerations, gangrene and muscle atrophy may be evident. Bruits may be auscultated with a stethoscope. Peripheral pulses may be diminished or absent. Examination of the peripheral pulses is an important part of assessing arterial occlusive disease. Unequal pulses between extremities or the absence of a normally palpable pulse is a sign of peripheral artery disease. The presence, location, and extent of arterial occlusive disease are determined by a careful history of the symptoms and by physical examination. The color and temperature of the extremity are noted and the pulses palpated. The nails may be thickened and opaque, and the skin may be shiny, atrophic, and dry with sparse hair growth. The assessment includes comparison of the right and left extremities. Check the medical history to help find the cause of occlusion. It is important to learn the cause and the source of the blockage in order to treat it properly. For example, atrial fibrillation raises the risk of an embolism, while peripheral artery disease raises the risk of a thrombus. The diagnosis of peripheral arterial occlusive disease may be made using different tests. These tests evaluate blood flow in the hands, fingers, ankles, feet, and toes. It evaluates how quickly or thoroughly wounds heal, and it evaluates the extent of narrowed or blocked arteries. Continuous wave Doppler or CW Doppler is a method used in ultrasound imaging to measure blood flow velocity. Next test is angle breaking index. It is a non-invasive test used to assess blood flow in the legs and arms and diagnose peripheral artery disease. Next test is treadmill testing for claudication. This test helps confirm the diagnosis of peripheral artery disease and assess the severity of claudication by measuring walking distance before and during pain onset. Next test is duplex ultrasonography. This ultrasonography test examines the blood flow in the major arteries and veins in the arms and legs. Next test is computed tomography angiogram. It uses a CT scanner to produce detailed images of blood vessels. Next test is peripheral angiography. It is a procedure that uses X-ray contrast to look at the blood vessels in the legs. Acute arterial occlusion is a medical emergency that needs a fast and accurate diagnosis. Every minute and every hour make a huge difference in the outcome. An occlusion may cause permanent damage to the limb within 4 to 6 hours. That is why it is important to seek emergency care immediately if a person has symptoms. Early diagnosis and treatment are essential to keep the affected limb viable during acute arterial ischemia. Treatment depends on the type of blockage a person has, where it is located, and the overall health. Acute arterial occlusion is life-threatening, so the main goal of treatment is to save the life. Related goals include restore blood flow to the limb, save the limb, prevent more blood clots from forming. Generally, patients feel better and have fewer symptoms of claudication after they participate in an exercise program. If a walking program is combined with weight reduction and cessation of tobacco use, patients often can further improve their activity tolerance. Patients should not be promised that their symptoms will be relieved if they stop tobacco use. However, because claudication may persist and they may lose their motivation to stop using tobacco. In addition to these interventions, arm ergometer exercise training effectively improves physical fitness, central cardiorespiratory function, and walking capacity in patients with peripheral artery disease claudication symptoms. Anticoagulant therapy with IV unfractionated heparin is started to prevent thrombus growth and inhibit further embolization. Antiplatelet agents such as aspirin or clopidogrel prevent the formation of thromboemboli, which can lead to myocardial infarction and stroke. Aspirin has been shown to reduce the risk of cardiovascular events such as myocardial infarction, stroke, and cardiovascular death in patients with vascular disease. However, adverse events associated with aspirin use include gastrointestinal upset or bleeding may be present. Percutaneous catheter-directed thrombolytic therapy using alteplase or urokinase is recommended for acute arterial ischemia of less than 14 days. The healthcare provider inserts a catheter into the femoral artery and moves it to the site of the clot. The thrombolytic drug is continuously infused. Thrombolytics work by directly dissolving the clot over a period of 24 to 48 hours. Pentoxifylline and xylostazole are medications used to treat intermittent claudication. Statins improve endothelial function in patients with peripheral artery disease. Studies suggest that statins improve symptoms of intermittent claudication and also increase walking distance to the onset of claudication. To restore blood flow, the thrombus is removed as soon as possible. Option consists of surgical thrombectomy, that is recommended procedure, percutaneous catheter-directed thrombolytic therapy, percutaneous mechanical thrombectomy with or without thrombolytic therapy, or surgical bypass. In patients undergoing embolectomy, unfractionated heparin should be followed by long-term anticoagulation. Close monitoring is required to make sure the catheter does not move and the patient does not bleed from the catheter insertion site. Surgical revascularization may be used in patients with trauma or with significant arterial blockage. Amputation is done for patients with ischemic rest pain and tissue loss in those whom limb salvage is not possible. Limb salvage refers to surgical procedure aimed at saving a limb if the patient is at risk for further embolization from a persistent source. For example, chronic atrial fibrillation, long-term anticoagulation is recommended.